This is improving quality of life with surgical options for Parkinson's disease. And we have a few members of our Center for Neurological Restoration at the Cleveland Clinic DBS program. So speaking will be Dr. Michael Guskowski, Patty Clark, who will have a patient scenario, and myself, who also has a patient scenario. So enjoy.
Good afternoon, everyone. As you can see, I'm Michael Guskowski. I'm a movement disorder neurologist. I've been with the clinic for this is actually my 16th year with the clinic. So I've been doing movement disorders exclusively, and this is talking about deep brain stimulation is a procedure that I've been very interested in since I was a resident. So we all know how Parkinson's affects the brain. It's the loss of dopamine, and the discovery of Lewy bodies within the brain, which is the sign of cell loss. Parkinson's disease symptoms are found when approximately 60 to 80% of the dopamine producing cells have been lost. These cells are within the substantia nigra, which is if you were to look at a fresh brain outside of the skull, you cut it, you'll see a black line. In healthy individuals, this slice looks like two thick black eyebrows, but when you have Parkinson's disease, these black eyebrows tend to be very thin and gray and even absent. This black substance is actually melanin. It's the skin pigment, and it correlates with the loss of dopamine. It's a byproduct of the production of dopamine. So, dopamine is a neurotransmitter, and that is what's involved in the cells within the brain communicating. So when you don't have that, cells don't communicate, and you have poor function. So the mainstay of treatment is levodopa. We've known about levodopa since the mid-60s, but Sinemet, which is a combination of levodopa and carbidopa, has been available since 1972, so we're 52 years into this. This is the best treatment for Parkinson's disease. It's not without its side effects. So it's not without its side effects. So, Parkinson's treatment is pretty straightforward. The goal is to, get above. It's basically an off switch. You want to get above. Everything above this line is on. Everything below this line is off. Once you get above this line, you turn on. Early in the disease, it's pretty easy. We give people levodopa, they get above the line, and they turn on. And so when you give a big dose of levodopa, they spike up, they do well, and they stay within this peak period in the sweet spot over here. Eventually, as the disease progresses, you get this top line that comes in. This is where dyskinesias come in. Dyskinesias in and of themselves aren't necessarily a bad thing. They just tell us that you're getting a little too much levodopa. And so this is where it can be a problem. You're getting extra movements. Now, my experience is, and I'm sure Shannon and Patty may agree with me, many patients are afraid of dyskinesias, but once they have them, they're pretty happy with them because they're actually on. They feel their best. They just have extra movements. But dyskinesias can cause falling. They can make things more difficult, and families are usually very worried about this. But as the disease progresses, this window between being off and having dyskinesias gets thinner and smaller, and it becomes harder to kind of get a nice to find the sweet spot. So what we need to do when we treat people with Parkinson's is try to fix this problem, fix the broken circuit. So deep brain stimulation offers this option of giving you basically back half your day. So if you look, your off time is generally about 50% of the time. The typical patient before DBS, 25% of the time they're on, 25% of the time they're on with dyskinesia, and 50% of the time they're off. With deep brain stimulation, they can get about 50% of their time back. So 75% of the time on without dyskinesia, and a much smaller percentage of the time off and on with dyskinesia. So who is the ideal DBS candidate? This has to be a person who has idiopathic Parkinson's disease. So, 60 years ago, that would have been everybody who has Parkinson's. But over time, we know that there's many different types of Parkinsonisms. So we have to be clear that this is someone who has Parkinson's disease. This has to be a person who has a very good, reliable response to levodopa. And we have to be sure that this is someone who has Parkinson's symptoms that are amenable to DBS. So these are people who have symptoms that are tremor and stiffness and slowness. Dyskinesias can get better, and they have a short medication response. And we also want to make sure they don't have any underlying medical problems, like severe depression, anxiety, memory loss. I look at it this way. There's really 4 reasons you can't do DBS. 1, someone has terminal illness. Makes sense. They may not be able to get through the programming or the surgery. They have dementia, which can be made worse by surgery. They have severe untreated depression. And the last is they physically can't have surgery. So these are people who may have anticoagulation issues, heart issues, breathing issues. They may have an anomaly in their brain where a blood vessel goes right through the area we want to put an electrode. So what do we think about as the movement disorder program? We think about, does the patient have Parkinson's disease, or do they have one of the variants? And having a variant is about 25% of the time. So if you were to kind of place a bet, 3 out of 4 patients with Parkinson's symptoms have Parkinson's disease. What does the patient expect out of surgery? And this is where it's our job to educate patients and to say, if someone has, balance problems, they have blood pressure problems, they have memory problems, that's not going to get better with surgery. Have patients had a really good trial of medication? Some patients come to us and they've just started levodopa. We'd like to see people have a diagnosis for at least 5 years, and also to have tried levodopa. You have to try levodopa. Levodopa experience and how you respond to it is the best indicator of how you'll do with DBS. Some patients come to us for evaluation, and if we add one of the medications that Shannon talked about in the earlier presentation, may save them from surgery. We look at other, so we'll talk about the evaluation, but we look at other things. Do they have good, care at home? Is there a risk for dementia? Is dementia developing? All, these may be concerns that they may have a poor outcome. So why would medications not be enough? Some patients, when they take Parkinson's medications, may find that they take levodopa every couple of hours. That may be a very difficult regimen to take, and they may miss doses. So that would be somebody who may be a good candidate for DBS. Or they have early wearing off or frequent cycling of medications between off and on states. Sometimes tremor does not respond well to medication, but we know that tremor will respond well to DBS. People who have troubling dyskinesias and medication side effects. There's some patients who never get over the nausea of levodopa, but DBS will help them reduce the levodopa and potentially not have as much nausea. Now, this is very important. What are the realistic expectations from surgery? We would expect improved tremor, improved dyskinesia, less, cycling between off and on times, a longer benefit throughout the day, improved bradykinesia, less dystonia, which is cramping, which you may see when you're in the off state. Depending on the target we choose, there's a couple of different targets, and we as a center will discuss which target to choose. We may be able to reduce your medications by up to 50%. So if you're taking it, 6 times a day, it's down to 3 times a day. Or you're taking 10 tablets a day down to 5 times a day, five tablets a day. And potentially improved off freezing. What does not get better? We don't expect people to have improved on freezing. We don't expect people to get improved balance and walking trouble. Memory does not get better. If someone has memory issues, sometimes the memory issues get worse. Swallowing, bladder function do not get better after DBS. Blood pressure control problems, orthostasis, will not get better after DBS. Symptoms in the middle of the body, so if they have a mouth tremor, may not get better. Patients with constipation, bladder control, impotence, those symptoms will not get better with DBS. And if a patient came to me saying that would get better, it does not get better. So what my discussions are with patients is, what is the goal of surgery? What are they looking to improve? So this can lead to some very difficult conversations. And Julian Fellows is the creator of Downton Abbey. But we have to be realistic. Hope is great, but some patients get great responses to DBS for things that we don't expect, but some symptoms do not get better. So how do we go about selecting patients for DBS? Well, they see myself or one of my colleagues in movement disorders, and they undergo the DBS evaluation, which is over 2 days. They get the levodopa response test, which is the off-on test, which is where we ask you not to take medications for about 16 to 24 hours. You're tested in the off state, you're given your medications back, and you're tested again to see what improvement you get with the levodopa. And if it's a meaningful response, that is in your favor to be a candidate for DBS. You meet with us, we talk about your goals for surgery. You get evaluated by neuropsychology for dementia, depression, social support. You're evaluated by neurosurgery to see if you're a good surgical candidate, because you get brain surgery, but you're also getting a surgery to implant the device under your collarbone. So to make sure that you can tolerate the surgery. You get an MRI of the brain that helps us look to see if your brain's safe to proceed to do a DBS. Also in here should be a CAT scan, because we also evaluate you for the high frequency ultrasound. We meet as a committee, review your video. The offline test is videoed, and we make a decision, and we give you the option of whether to consider the DBS or go forward with it. I have many patients who get evaluated, find that they're a candidate, and don't go forward with it. Or patients who come in wanting high frequency ultrasound and end up not getting and going with DBS. You're seen by anesthesia for the surgery. And then the DBS is in two parts. There's a stage 1 where the actual electrode is placed. And if you're getting bilateral surgery, that's 2 separate surgeries. And then the stage 2, which is the actual generator or battery, which is placed under the collarbone, and that connects it all together. And then you start your programming. So DBS is changing. There's a lot new options for DBS. Now all the batteries are MRI compatible. Medtronic's battery is 3 Tesla, whole body. Abbott and Boston Scientific are 1.5 Tesla, which is the strength of the magnet. They all have directional leads, which give the programmers more options on programming, and you'll see what advantages what that provides. So in the past, what you could do in the past was basically program over here off one contact, and you get a ball of charge. You could program across 2 contacts and get which was basically shaped like a hot dog. Now you can do this really exquisite programming of sculpting the electrical field, which is what our programmers do. And Medtronic has the ability to do brain sensing, which is a really, interesting feature for DBS programming. So these are all the directional leads. The 2 middle contacts are broken up, and it allows the programmer to actually sculpt these fields, so it can come off as almost like a clover leaf. See, here it comes up. There's a ball of charge. Second one's a ball of charge too. The first ones, as they go up each contact, is going to be a separate ball. Now it's going to be each directional, so it really sculpts it here. So here, if we want to avoid or actually try to target the green structure, we can do that now with greater efficacy. The goal here would be the target here is trying to avoid it, but if you want to, you could actually target it if you wanted to. So all the companies have rechargeable batteries. They'll give you about 15 years. Medtronic's battery has that brain sense technology. They have a rapid recharging, 15 years. I got this off their website. They have the thinnest profile, so this is what goes into under the collarbone. Typical number of days is about 9 to 12 days between recharge, but it can be as little as 15 minutes if you charge daily. They have a new battery technology, which is really exciting. There's minimal loss of capacity. So this is like if you have a cell phone where your cell phone could go for a couple of days between recharging. Now their battery, after about a year, it's every day you have to charge, or twice a day, or twice in a day. Their battery does not lose capacity. that's pretty exciting, and it has the brain sense, which is exciting. Abbott has a rechargeable now. Their charge can last up to 37 days on nominal settings, and they have the smallest rechargeable deep brain generator, and they have remote program capability. Boston Scientific, they can go 30 days recharge free, and it's and they're all MRI compatible. So I said Abbott has the remote programming. So you could be at your house. So if you ever have an emergency, we can get the you can do programming from your house if you need to. So the last thing I'll talk about quickly is MRI focused ultrasound. This is a newer way to do an older technique. So DBS is based on doing what we call thalamotomies, which is where we kind of went into the brain and actually injured the thalamus to get rid of tremor. DBS allowed us, they put an electrode in there, you put electricity in there, and it kind of disrupts the field and it reduces tremor. MRI, guided ultrasound, allows ultrasound to go in and it damages the thalamus. It causes a lesion. Many patients come to me saying they want a procedure that's non-invasive. I say, so you mean DBS? DBS, for even though you are cutting the scalp, drilling a hole in the skull, leaving an electrode, tunneling a wire to a battery, I still would argue is less invasive because you can turn it off. You can change the programming. As I said, you saw what you can do with the electrode. You can program it. You can program it from your house if you need to. You can turn it off if you have to. Ultrasound, what you get is what you get. You're stuck with it. You can see an MRI and see it there. If we ever have to take that DBS electrode out, after about 4 weeks, you see a little strand of spinal fluid in the track. So it's, you know, it's within reason, it's less invasive. It doesn't really damage the brain, but within reason. So why would you get ultrasound? Ultrasound is exclusively for addressing tremor. You're not going to address, you know, stiffness, slowness. It's definitely not going to fix, definitely none of these procedures are going to touch walking. But ultrasound will not address stiffness, slowness. It will not reduce medications. Initially, it's only for one limb. So if you have somebody with severe tremor, maybe an option. After about 9 to 12 months, it'll be both. You can do the other side. And it's usually more effective for a hand. It's not going to be someone who has like a tremor in the shoulder. I've had a few patients who've gotten it for Parkinson's tremor. You know, I still would prefer DBS. I think it's a better option overall. So, but we'll go from there. All right. And I think next up is Patty and Medtronic.
Do we advance the slides up here? So I'm Jim Adler with Medtronic. I'm pleased to be here. I'm only going to speak for a few minutes on a few slides, and then Patty and Jesse are going to be the main event here. But we want to start with a little animation that explains how BrainSense works with Medtronic.
When a person with akinetic, rigid Parkinson's disease exhibits near normal mobility, brain signals may show moderate synchrony with minimal frequency peaks. When a person with Parkinson's disease experiences movement challenges, brain signals may be excessively synchronous with a peak at the beta frequency band. The Percept PC implantable system for deep brain stimulation from Medtronic is the only system that can chronically detect and measure signals from the brain. BrainSense lets clinicians capture these signals from the brain both during and between visits, and this personalized information, along with other clinical information, may be used to inform clinical decisions.
So what makes Medtronic DBS with brain sensing technology unique? It's really the ability of the device to track a patient's brain signals, as the video suggested, chronically, 24 hours a day if necessary, when we have the device in sensing mode. And it's really not just a snapshot in time with a programming session. This device is really built to stay with the patient and their journey with Parkinson's disease. As it is a progressive disease, we see signal changes that occur throughout the life of the patient's time with that device, and it's very nice to have this information as nurses and physicians are programming patients. When we're combining this data with the clinical expertise, I think the other important thing to recognize too is the MRI capabilities with Medtronic PC and RC as 1.5 and 3T Tesla, and the device is engineered to adapt. Since we've had that wonderful video of Bob with Percept PC, we had approval of our new Percept RC back in January, which is an identical programming software as to Percept PC, but it is much smaller. And we think it's smart and adaptive. So it's the thinnest device in the market with a 15-year battery life that's really impervious to any capacity fade in the battery like an iPhone or a watch would have. We expect the patient's recharging experience to be identical from day 1 to year 15. So you won't be charging more frequently as the device ages or the more times you charge your device. And as I said, it's 37% smaller than our previous device. I think one of the neat things about the technology is that we partnered with NASA to come up with proprietary coatings for our extensions and our leads that allow us to have really exquisite readings of these brain signals, because we're able to weed out a lot of noise and artifact from the heart and from the brain to give good information for the programming appointments. This is what the charger looks like with an app on the phone. You can monitor your charging, see what kind of connection you have. Next, here's Patty.
Hi, my name's Patty Clark. I'm a nurse practitioner at the Cleveland Clinic. I've been with the clinic for 15 years, 7 of those in neurology and 2 in movement disorders specifically. And a big part of my job is programming patients' DBS once they're through all the surgeries and stuff that Dr. Guskowski talked about. So for our presentation today, I'm going to talk about a patient that I programmed. His name is Jesse Parkinson. And he was actually one of my first patients. I had started in December, and so he was one of the first patients that I saw from his on-off testing all the way through programming, and continue to see for follow-ups today. But he's here with us today, and he has agreed to be kind of off meds and on very low stimulation, so that we can get an idea of what he looks like both with and without. But at the time, he was 56 years old and he was diagnosed with Parkinson's disease in 2017. His symptoms began on the left side of his body, and they've remained a little more prominent on the left throughout his Parkinson's journey. His primary symptoms include tremor, both in his arm and his leg, slowness, stiffness, occasionally some dragging or shuffling, particularly of his left leg. He had surgery. He had bilateral surgery where the lead was placed in the STN in June of 2023. Prior to that, he was taking pretty high doses of Rytary, which is a formulation of carbidopa-levodopa. And he was taking it every 3 hours, and even taking it that closely together, he was having wearing off. Before Rytary, he had been on immediate release Sinemet, which had even more wearing off for him, and caused some fatigue. He wasn't able to try what's called a dopamine agonist because of his job and the risk for fatigue and impairment. So this video is from his off testing. So this is before surgery, and he came in off medications. And this is just a little picture of his most prominent symptoms at that time. So that's his right side. And then you can see a lot more rigidity and less dexterity on the left, as well as tremor.
And then with your right hand, open and close your fist. Okay, same with your left.
You can hear his leg tremoring in this video too.
And then with your right hand, turn.
December, November, October, September.
And then this is just a picture of his rest tremor.
May, April, March, February, January.
Okay, perfect.
So Jesse was implanted with the Medtronic system, which has brain sensing leads. Only Medtronic has this technology, and it's nice because it gives us some insight into what's happening with your symptoms while you're outside the clinic. So in this picture, it's kind of showing, we see you really for 1 hour, 2 hours here and there in the clinic, and we can get a picture of what your symptoms look like depending on when you last took your medication. But with the brain sense technology, it's reading your brain waves and thus kind of a picture of how bad your symptoms are 24 hours a day. So this is a picture of what Jesse's brain waves kind of looked like with that data that we collected before he was programmed. So you can see there's a lot of fluctuations, highs and lows, kind of those lower ones on the left side and the right side are times when he was sleeping and the waves were suppressed by sleeping. But a lot of ups and downs, as well as the number on the side there, that it is a kind of the level of, I guess, the severity of the signal. And so you can see on the left side there, that's like at 4,000 on one side of his body and 1,400 on the other side of the body. So we'll compare these to what he looked like after programming, but this is a picture of before he had any DBS. So DBS programming is not as easy as turning a switch from off to on. I would love it if everyone went through their surgeries and had that month waiting period and it was just pressing a button and your symptoms were kind of idealized. But there's a lot of things that we have to think about when we program. How long it's been since your last medication, what contact we're going to use. So on that lead there, you can see there's 4 contacts. As Dr. Guskowski said, those 4 contacts are further divided into segments. And then we look at amplitude, which is the strength of the signal, the density of the energy that's putting out, and then also the frequency, how fast it's been putting out. So all these things can be adjusted. So there's literally millions of combinations. And it's part of my job and the other programmer's job to find out what are the best settings for you. So how does Medtronic BrainSense help us do this? So we run something called a BrainSense survey. Patients come in for their first programming visit, typically off medications, and the stimulation's been turned off. And the survey takes just a couple minutes, and it can help us narrow down which contact to use, kind of what is that sweet spot that we want to direct the energy toward that will give us the best symptom control with the least amount of side effects. So when we run a BrainSense survey, we get a kind of a table that looks like this. And the first thing we look at is where on the lead. So in terms of from bottom to top, where on the lead is the signal the strongest? So this is actually a picture of Jesse's BrainSense survey. And so we look at that highest peak, which corresponds to kind of his worst symptoms or that abnormal wave coming from his brain. And that's the signal that we want to kind of suppress using the DBS. And so on Jesse, that highest signal was on those two those two contacts in the middle. The next thing we look at is whether the signal is directional. So now we've narrowed it down to, is it higher on the lead or lower on the lead? Now we want to look kind of in a circular view. Is the signal higher on one of the contacts? So from one side of where it is. And again, this is a picture from Jesse's survey. And the A signal for his was kind of closest to the sweet spot. You can see B and C, which are the yellow and blue lines, are high as well, but really the A one shows a little bit of directionality. So what we do then is once we've found that signal that we're going to try and suppress, we do something called BrainSense streaming. And so we're actually going to do this live with Jesse today. Jim's going to get him set up. But we start at 0 milliamps, so no energy. And then we slowly kind of go up in energy. And the things that we're looking at are his symptoms getting better. So does he have less tremor? Does he have less rigidity? Is his dexterity improved? Is he able to do those things kind of faster and more fluidly? The next thing we look at is if the patient is having any side effects. So are they feeling any numbness, tingling? Are there speech changes? Sometimes with too much stimulation, you can have the opposite effect of helping rigidity, and you can have kind of muscle cramping and straining. And then the last thing that we look at is as we track that wave and increase the amplitude, are we indeed suppressing that wave that the energy we're putting out? So again, Jim and Jesse, I think, are set up. And so we'll be able to see kind of a picture what I see and the patient sees on the tablet as we're doing programming. In clinic, we go slowly up by like 0.5 milliamps at a time and just see the effect. Because Jesse has been programmed for a while, we know that he tends to do really well at about a 2 or above. So we're going to have him kind of go right up to that. I'm getting the the thumbs up from Jesse. His tremor's getting better. And then as we make changes, unless we're really at higher amplitudes, it's nothing that's uncomfortable or that the patient necessarily feels other than benefit to their symptoms. But you can see that wave is being suppressed, and Jesse's tremor is gone, and then things like rigidity and dexterity take a little bit of time to kind of get better. But that's it. And then I'll see again, just because Jesse's so gracious and he agreed to do this, I'm going to put it back down to 0, and you'll see those waves start to come back up. It doesn't generously drop you down either, just like very still. So that's how BrainSense can help us. So without BrainSense, we're looking at his tremor, we're looking at his dexterity, we're having to do a lot of things, and we still look at those things and make sure they correlate to what we're seeing on the screen. But it's really another tool that can help us get to that efficient programming that, again, is the most effective for your symptoms with the least amount of side effects. I'm going to put Jesse back on his preferred settings, and then we'll finish up. Okay. So this was my backup slide in case we weren't able to get the tablet to work, but you can see that first arrow, we're at 0.5 milliamps, then up to 1, 1.5, 2, and you see that flatten out. That little red arrow, actually, I had gone a little bit above 2, and he started to have some side effect, and so we had gone back down. Oh, we don't have to play these videos. We can just go to the next slide. So this is, again, the before. So lots of fluctuations, very high LFPs there on the left, and obviously more symptoms. And then this is a picture of what his brain activity looked like just this August. So he had been programmed for a year, and so much fewer fluctuations, improved symptoms. You can see one side is a little bit better than the other in terms of his symptoms still and the fluctuations. Some of that is, based on medication times, that kind of thing, but overall just much, much smoother. So this is kind of a picture of like the video showed. So what BrainSense can show us when you're feeling off with those high spikes, and then when you're feeling good, it's kind of smoothed out and more consistent. And then this, I don't know if this will work, if it's connected, but this is a little video that Jesse made actually, and have put on YouTube. I don't know if it'll play if you click on the link. This is from his first programming visit.
My proud moment.
I hear the audio, but I don't think we'll be able to see it. Okay. Oh, yeah, so Jesse made this video. I was showing this to my husband, and he asked if I had put in the editing of the crab claw, and I was like, I would never put the patient had a crab claw.
Wait, in the spot. So we usually see better results.
Yeah, through here, through there to your device.
So then we turn it on. So I love that video because it's just kind of everything put together in 15 seconds.
You're not shaking.
But we're going to have Jesse come up and talk a little bit about his experience and his use with Medtronic. And any questions you have, we can answer that after that.
Yeah, through here.
And Jesse, thank you again for agreeing to be both off meds and off STEM. I appreciate it.
It's my pleasure, Patty. It's been great working with Cleveland Clinic and Medtronic. Dr. Appleby, you're out there somewhere. Dr. Appleby got it started down this road toward, yeah, I see you, toward DBS, and then Jim and Patty and Dr. Nagel took over from there. But it's been an unbelievable process. It went so much smoother than we ever anticipated. I mean, 2 brain surgeries and a brain surgery here you'd think is a big deal. Cleveland Clinic has it worked out so well that it's an amazingly well-oiled machine there. But I just want to I'm not going to be here very long. But before I had DBS, it'd be very hard for me to walk to the back of that room without stopping and resting. I'd be dragging my leg, and it was just really hard to do. The day they turned me on, that day that was in that video right there, we went to Niagara Falls to celebrate, and we both walked 16,000 steps. And since that time, I've been motorcycling in the Andes. I've been to Korea on a business trip. We've been all over the place. We've only been home three weekends at all this summer. I have my life back, and she knows how I feel about it. I mean, I cry all the time talking to her because I'm so blessed to have been exposed to this kind of thing. Now, I know Dr. Guskowski has to tell you the truth, and that's what they told me up in front of it, too. They have to tell you that it can't always go this good, but boy, it can go this good, too. It can go better than you ever think it did. You can have your life back if you if it was like I had, right? I mean, I'm not a medical professional, so you can't sue me for saying that, right? Anyway, I think they're going to give my contact information later. I have the details of the surgery all mapped out from a patient's point of view. I can email you to show you if you decide to go down that road, what you're in for when the time happens. And then Jim and Patty. Pat, you won't see Patty until after it's all over, but Jim will help you going through the surgeries, or somebody else from Medtronic, or I'm sure the other companies do too. It's a really good process, guys. If you're eligible for it, I encourage you to do it. Thanks.
All right, so we just got one last little segment here, and this is another company that does deep brain stimulation, and this is Abbott. They have their own special little, no, I shouldn't say special little. They have a very cool technology that we utilize very often at the Cleveland Clinic. We have people that come from out of state to have their surgery here, and this technology allows us to program them without them having to leave their home. So I'll let one of them talk just a little bit about their company. Yep.
Hello, everyone. I'm Jessica. These are my teammates, Steve and Victoria. Here's our lovely pictures here. We're just going to talk a little bit about what Abbott has to offer. But we'll start off with a quick video here.
Is it too much for you?
No, I'm good. It just makes me appreciate it all.
Okay, now I'm going to turn the right DBS off, which controls the left side of your body.
God. I can't believe this. Holy
I'm gonna put them
Okay,
back
please
on.
put them back on. Oh my God.
Okay, so we're gonna start with the left body first. Turn that one on. You're back on.
Look at that. This is amazing.
That is amazing. That's
Truly amazing.
These are some components that Abbott has as part of our portfolio. We use Apple products, so our patients have a patient controller. It's an iPhone SE. Our clinicians program with Apple iPads, so those are two things in the middle. And then similar to the other companies, as Dr. Goskowski talked about before, all of the leads are pretty similar with the directional stimulation technology. Those leads are implanted into the deepest part of the brain that affects Parkinson's disease and connected to wires underneath the skin, kind of behind the ear, down the neck. No. And then connected to extensions that attach to the battery that's in the chest, again, all underneath the skin. So this kind of just highlights the details of the first part of the procedure.
I'm Steve, so part of that Cleveland Clinic team here with Abbott. I'm 6'8", by the way, if you're wondering. So we're the company at first. So we were the first one with the directional lead, first completely wireless, secure and Bluetooth wireless technology enabled device. First with the patient controller app, right off the Apple App Store, and first with remote programming. So a little bit about our devices: compact, long-lasting devices. Easy to use, intuitive technology, really simple on the app to use. We'll teach you. My team will teach you. It's pretty simple. We can teach you in about 5 minutes. And remote programming, which Shannon's going to highlight here in a minute. Upgradable technology. So what does that mean? So as new technology comes out, devices do not need replaced. We can upgrade the software with the iOS software through Bluetooth. So as something cool comes down the road that we don't even know about yet, our devices are able to do that without replacing a device. So if you would get a rechargeable device and it's going to last, there's no end of life on our device, we can upgrade that to the newest technology as it comes. And those are all the upgrades we've done since the launch in 2017. All patients that were implanted in 2017 have access to all those, even though they're released after the device was released. Jess went over this a little bit. iOS patient controller. We do use an iPhone. We will provide the iPhone to the patient. If you do have an iPhone of your own, we can go right off the Apple App Store and put that on your device, so you're not carrying around two controllers. Very nice, simple. It's in your pocket. If you need to make a change when you're out to dinner and you notice a tremor coming through, you can look like you're text messaging on your phone, and you're really increasing your amplitude of your device to help you with your tremor. So we're redefining rechargeable. What does that mean? We have the smallest IPG on the market for a rechargeable device. Lowest recharge frequency. You only have to recharge the device 10 times a year or 37 days between recharges. A typical patient we still want them to do it once a week. If you do about once a week charging, you're about 30 minutes a week. So if you're watching a TV show or watching the news on a Friday night, throw on the rechargeable and you'll be good to go by the time the news is done. Also, remote programming capabilities. With that remote programming, with rechargeable devices, we know charging can be an issue. With remote programming, if you go home and you completely forgot because it was overwhelming that first day, we can get on a virtual visit. Programmers can get on a virtual visit with you and make sure you're doing it correctly once you get at home. That's a big thing with patients. Hey, it worked in the office. I don't know if I'm doing it right. If you connect with them remotely, they know if you're doing it right. So it's a very nice feature of our device. We have no end of life on our device, but we will guarantee charging for the first 10 years of that device, and we will pay the full out-of-pocket cost for that device if the charging comes down over time. And we do also have a non-rechargeable device, a primary cell device. We have clinical evidence. 50% of our batteries lasted greater than 5 years if you decide to go with a non-rechargeable device. That's a set it and forget it device, put it in your chest, and don't have to worry about charging it every week. It's a nice device as well. Nearest for virtual clinic. So your patient end will look just like a FaceTime call. So I don't know if people have done FaceTime before. It's basically in the simplest form of secure FaceTime with the provider such as Shannon on the other end. You see a nice picture of Shannon. And her end, she has multiple different views that she can see the picture of. The key is just basically set it up on your desk, sit in a nice chair, have the programmers have it above your about mid-chest and up so the programmers can see you. And that's the stats on how many patients have done it. And we're going to skip this video because Shannon's going to do a video with one of her patients. Thank you for Shannon getting that done so quickly. We appreciate you. And thanks the Medtronic team. You guys are great as well. And your patient, fantastic story. So we'll let Shannon go. Oh.
No.
No, he has to click you.
I have to click. Oh, he does.
Yeah, he's clicking.
Okay. So I just want to point out that as you've seen, we've got two really great companies here. There's actually also a third company that you would see outside Boston Scientific. And, you know, this seems overwhelming, like what device, what would I pick? These all sound really cool. It's true, they are. And generally, if you're confused, we will step in and tell you which device we think would be best for you. So a lot of our patients that come from out of state, we will of course think and talk with them. This programming can be multiple visits. Are you willing to drive to Cleveland for multiple visits after your surgery? If that's something that's very, you know, scary to them and they don't want to do that, then we'll consider Abbott for them. But we go on many different decision points, and then we usually will give you our suggestion, what we think is best. So this is actually a pre-recorded virtual visit from Thursday. A patient of mine, Jeff, who lives in Indiana, he has just really taken to the virtual programming, and we've had great results. And so I just wanted to highlight that for you.
So do you have your device with you?
Yes, we do.
Awesome. All right, so I want to connect through there because the point of this is to show, we're trying to show some, the audience members of Empower You what it's like to do a virtual visit. And so
okay.
You guys have been so good with the tech savviness of doing this. And so I figured this wouldn't be too stressful for you.
No. Okay, so I'm also, do we want to do a quick drive on or just go for it? In other words, want to make sure we can make the connection and everything?
Yeah, go ahead. Yeah, let's get on. I still gotta get my password in, but go ahead and enable it.
Sometimes the patients are better at it than I am.
I'm connecting right now.
Perfect.
There we go. Okay, therapy is on. Neuro virtual clinic is off. So I'm going to say neuro virtual clinic on, right?
Yep.
Make sure you won't speak too fast.
Got it. Okay. So, and then when it comes up, make sure you mute the video sound, because that's when we'll get the feedback.
So,
and what we're doing here, he actually does an epic Zoom chat with me on the computer, and I can help him through this.
So we need to start.
Yep.
Which is then why I tell them to mute it.
Okay, I'm going to mute the microphone on the cell phone and keep the mic on the computer going.
Perfect. Yep. Have to wait for mine. Okay. Alrighty. Oh, wait a minute. I hear myself. Try again to mute it. Okay.
Okay, now it should be muted.
We're good. We're good. All right.
Operator on this side. It's Teresa's fault. She let me do it by myself.
We don't usually let you do it all on your own.
No.
Yeah, we do.
All right. So, like I said, this is, we're going to just kind of do like a quick little assessment and just have a little conversation to show how easy this can be to do virtual programming from a different state. So you're in Indiana, I'm in Ohio, and we're going to work with your DBS settings, right?
Yep.
Okay. And would you tell, like, what do you think, has it been like a stressful or cumbersome experience for you guys when you've done virtual visits, or has it been really like a nice experience for you?
It's been nice. In fact, I'm nitpicking. I'm a process guy. I can't think of a thing you could do to make it easier. Frankly, it was really
awesome. That's great. And then I think the thing that, how many hours away are you from Cleveland?
6,
almost 7, 6 and a half.
6, right? And some of our visits last like 15 minutes, right? Because you're doing so well. So to save a 12-hour round trip drive, like
for a
this
15-minute meeting
in a hotel.
And frankly, it wouldn't go any faster if I was on site. I don't know how it could. I mean, yes, because if I was there, you'd be saying the same thing. Well, how do you feel? And
right. Right. I'd probably have to add in a few things to make it worth your while. It would be like asking more questions or something like that.
Yeah.
But all right. And then I just kind of want to show them how easy it is. So for you and your tremors, a lot of the times I'll have you kind of, move your camera around so I can see your tremors. For other kinds of patients, a lot of times I'll have them like hold their arms up and show me what your tremors look like right now. Good. And were they bad when you would hold them like this before?
Yeah. Oh, yeah. In fact, this finger right here is shaking just a little bit.
Yep.
The tremors have picked up just a hair since we last talked.
Got it. All right. Well, I could even turn it up a little then, huh? Might as well give you something.
Well, look, I'm a free visit. No.
All right. And then I'm just going to show, let's see if I can show to my camera what my screen looks like. And so this is what I'm able to program, which is exactly what I would program if you were in the office.
It's out of focus. You have to pull. If you do, you have to back it off if you want anybody to see. You have to back that off.
Oh, really? Okay.
Is it better now? It's just the shit. No, put it closer. Is it me? It's just not in focus.
No, you know what? From your end, it might not be. On mine, I can see it, but so we'll see. We'll see how it looks. But and then so I'm actually going to bump you up just a little, and you tell me if you feel anything. Any change?
Yeah, that made the difference. The tremor was slight.
Yeah, it was. I saw it in your fingers when you were holding them there. So okay.
And you see it now, right?
Right. Yep. Yeah, it's definitely, actually it is, but that was easy. That kind of gives us our display of how well it does work for you. Okay, so now I entered that and I saved it, and then I'm going to run your test real quick just to check your system. So it turned off just now. And now it's back on. So that's as quick as a test can be. So if some people are only coming into the office to test their system, that's a long drive, right? So that's what makes this device so awesome.
Well, I remember we were looking at the options, right?
Yeah.
Our first thought was, well, who really cares? And then, of course, Dr. Machado had said, really, that was the way to go. Right, and we said we got to trust the experts. And I'll tell you what, I would. There's three things I would not change from this experience. Number one was using Cleveland Clinic, absolutely, I would. And then number two was the device, picking the device that we did. And number three is having the procedure done at all. There's just no. I'm really. In fact, a lady that I work with, her husband, they're coming up first week of October. First week of September. No, October to be evaluated.
Nice.
When her dad had Parkinson's, she said her husband had it, and I convinced him to come up to Cleveland Clinic.
So you're one of our many ambassadors.
I wouldn't go that far for you.
All right, so what I'm going to do is I'm going to log out of your device, so you'll see it disabling on your end.
Yep.
All right. And honestly, this is very similar to what a lot of our appointments how they go, isn't it? I mean, we get done in a couple minutes, you're feeling a little bit better, and that's it. So
there's one thing people might not realize, and that is I mean, I forget how bad. All I remember when we turned it on was Teresa and I went out when we left your office, And we had stuff that was long drives. So we sometimes had Mexican. And I literally remember crying and writing to him going, "I love you, honey," because I couldn't write.
Yeah.
But there's a comfort in the security knowing if I'm up in the Adirondack Mountains anywhere and I got a problem, I call you. We can take care of it right then and there. But
Right.
seriously, take some of the stress and worry away.
Right. Yeah. Instead of feeling like if you were to travel really, really far away, who out there would be able to help you if anyone was out there, right? So, yeah, that's a really good point. All right. Well, that's pretty much what we needed, and I'm hoping that this will be really educational for the people watching. And I also, I'm going to try to find your old video, and if it's okay with you, show what your tremors used to look like, because I think that's really helpful too for people to see. So,
not a problem. Anything that helps with some other people's fine with me.
Good. Awesome. Well, thank you so much, Jeff. And I'm so glad, I'm so appreciative that you came home from work, figured out how to get Microsoft Teams, or Teresa did. I don't know which one. But I think this will be really, really helpful. And then after the fact, just so you guys know, Empower You, all of our presentations and everything will be on YouTube. So you guys can watch them yourself too. So.
Okay, great. And the people at work, my team that you pulled me from, they're thankful too.
They probably went home early today.
That's right. Hey, thanks, Shannon. Anything you need to help us, let us know.
All right. Thanks so much, guys.
Okay, bye-bye.
Bye-bye.
So that literally is how quick the visits can go. And so if people are traveling, I would say even further than 2 hours, sometimes this is something that is really important to them. Now, if you're in the Cleveland area, there's a whole different other trajectory go down for decision making. So I don't know if we were able to get his original video, but that's okay because I think we're running over on time anyways. But all of the people that were up here are going to be up here for questions afterwards. So please feel free to come up and ask. And just know that everyone that was up here is an amazing resource for DBS. You can see we've got 2 wonderful patients who apparently cry all the time about it because it is that great. So we hope to be able to help more people that way as well. And that is it.